Assalamu alaikum. So
Walaikum assalam.
welcome to the our session number 6. So in this session, we are going to discuss the three scenarios. The first scenario, I will be the examiner, and Dr. Usman, you will be the candidate, right?
Okay. Okay,
So are
sir.
you ready?
Yes.
Okay. Uh, 60-year male patient has been brought in the emergency department with the history of hematomesis, and his pulse is the 140 per minute. His systolic blood pressure is 80 millimeter of mercury. So the internal medicine colleague, they are managing the patient. They have sent you a call to see this patient. So how will you proceed in this patient?
Now this patient has an episode of hematemesis, massive hematemesis, and he is hypotensive. And according to ABC, I will first of all like to maintain his basic vital signs and circulation according to ABC protocol. I will assess his airway, and because he is vomiting, there is a risk of aspiration. I will first of all secure his airway. Simultaneously, I will uh, tell one of my colleagues to pass two large IV cannulas and start fluids because he is hypotensive. At the same time, I will ask them to take the blood and cross match blood grouping and cross matching. Because this is a case of upper GI bleed, there can be the multiple causes. I will rule from by taking thorough history from the patient regarding any history of hepatitis B, C, any history of alcoholism, any history of hemochromatosis to rule chronic liver diseases,
There is no
history
history
of
of any
chronic liver
chronic liver
disease.
disease.
Okay, the differential diagnosis of acute upper GI bleed can be a mallory while resuscitating the patient. I will examine the patient. I will see whether he is responding to my resuscitation or not, and
He
his
is not, the
bleeding is
patient.
stopped or not.
Right. So the patient is not responding. You have given the 1 liter of the ringer lactate, and his vitals are the same. So there is
Okay,
no history
then
of
I
any
will.
chronic liver disease. There are no features of chronic liver
Okay,
disease.
okay. Then I will arrange blood, and simultaneously I will secure his airway because vomiting.
So
Because
airway has been
if
secured.
he Yes,
Okay.
and then I will request my gastroenterology colleague to do his after his resuscitation and stabilization. I will request gastroenterology colleague to do upper GI endoscopy to see any localized focus of bleeding. And at the same time, I will also request a radiologist to do his ultrasound abdomen to see whether the to see the texture of liver and
Liver is
any.
normal. So there is no evidence of any cirrhosis.
Okay, I will request a gastroenterologist to see which is the point of bleeding from the whether it is esophagus or it is coming from the stomach. And I would also ask him about the findings in the upper GI endoscopy if he can help me, and if he can manage by bending or sclerotherapy, or if there is any visible spurting vessel, he can clip it so that bleeding can be stopped.
Okay. Upon the upper the endoscopy, he has noticed that the stomach is full of blood, and he's unable to find out the source of the bleeding. So what will be your next step?
Okay, if endoscopically bleeding cannot be stopped, then we have a temporary measure. We can pass a Seng's taken Blackmore tube to stop the bleeding
There is
from
no
the.
there is no evidence of any. This patient is not a known case of chronic liver disease. The ultrasound is normal. There's no evidence of any sources.
Okay, then we will try to localize the source of bleeding with the help of angiography or radio labeled RBC scan.
How much time will you take for this radio label scan?
It will take almost 1 to 2 hours, and I will
One
keep
to
on
two hours.
resuscitating the. Yes, I will
Mhm.
keep on
But the
resuscitating the
patient,
patient.
see, patient is. Do you think is he's stable enough to undergo this scan, and where the facility is available?
Okay,
Do
if
you feel
it is
like
not
this?
available,
Mhm.
we can give him terlipressin, splanchnic vasodilator to reduce the portal hypertension. if he has any, and I will check whether he is taking anticoagulants or antiplatelet drugs. I will take thorough history whether he is taking anticoagulants. He has any previous history of
He's not
ulcer.
taking he's not taking any anticoagulant.
Okay, then I will try to localize the cause of bleeding. It can be probably a duodenal ulcer, or it can be peptic ulcer because esophageal varices are not there. So I will, if bleeding endoscopist is able to localize the bleeding, then he can manage it endoscopically.
So
Otherwise, I
he's
will
unable
arrange
to do
the
that. He has given you the idea that the blood is most of there's a pooling of the blood in the duodenum and the pylorus region.
Okay, then I will arrange, if he is unable to manage endoscopically, then I will alert the operation team and prepare the patient for emergency surgery because he can have bleeding peptic ulcer from the posterior duodenal wall
Okay, what will you
or
do?
stomach.
Okay, what will
I
you do?
will okay, I will take him to operation theater, and I will do duodenotomy and distal gastrectomy and see whether from where the
So you
bleeding.
will perform distal gastrectomy.
No, I will do gastrotomy from the duodenotomy. Sorry, I will perform
Duodenotomy.
the duodenotomy and see. Normally, most of the ulcers they bleed from the posterior duodenal wall, and this is a pancreatic or duodenal artery that bleed. I will
Duodenal.
take.
Hmm.
I will press the ulcer, and then I will try to take two sutures, one above or one below the bleeding points, or I will take the figure of eight suture to
What
secure the
will
bleeding
you use?
point. I will use absorbable Vicryl 20 with round body for
Mhm.
ligation of the
Okay.
vessel.
Suppose there's a large ulcer. Then what will you
Yes.
do? It's a large ulcer.
If there is large ulcer, then I can, if this facility of angioembolization is available, we can do angioembolization, or otherwise we
Now you
can.
have opened up.
Uh,
Now you have performed the duodenotomy. You notice there's a large ulcer. So the posterior wall of the duodenum is also described.
okay,
Not
then
close
we
it.
can. Okay, then we can do Bill Roth to distal gastrectomy, or Bill Roth we can exclude the duodenum, resect the portion of the duodenum that is ulcerated, and a distal portion of the duodenum will be closed, and I will perform gastrojejunostomy
Okay.
to
So
give the drainage.
right. So suppose this patient is having the signs of chronic liver disease. This is the known case of chronic liver disease. So how does the management plan change?
Patients with chronic liver disease, they normally bleed from upper esophageal varices because of increased portal hypertension. In this case, if it is amenable to endoscopic bending, I will request gastroenterologist to bend the bleeding varices, or he can apply endoclip, or if he can help
Okay, so
with the
so
give adrenaline injection.
endoscopy is unable to cure the bleeding. Then what will
Simultaneously, we can give splanchnic vasoconstrictors, such as terlipressin, and if it is endoscopist is not able to manage the bleeding, so we can temporarily, for the time being, because patient is actively bleeding, we will resuscitate the patient, and we can tamponade the esophageal varices with the Seng's taken Blackmore tube. Uh,
and then what is the next step?
and then because it can cause gangrene and necrosis of the if we keep it for the long time, we can go to radiological and surgical measures to reduce the portal hypertension. If we can go manage if
Before
facility of.
before before the surgical intervention, is there any other step?
Yes, they we have interventional radiology, trans hepatic trans jugular interhepatic port systemic shunt can be tried if
Okay.
a facility is
So
available to reduce the
before
portal
putting the
hypertension.
tips, what will you do?
I will resuscitate the patient and give him a splanchnic vasoconstrictor like terlipressin or
So what is the
octreotide.
contraindication? What the contraindication of putting the tips?
Tips, because if we are planning to do liver transplant in the patients with chronic liver disease, then it will be difficult post transfer to do the transplant with the
That
help
will be
of tips.
contraindication. Is it not the tips is preceded by the liver transplantation?
No, it's not
Okay,
the
fine. Okay,
contraindication.
fine. Okay, fine. Suppose the patient is hemodynamically stable. This is the same patient has been brought in the emergency department, but the patient hemodynamically stable. Now, how did the management plan change?
Patient is hemodynamically stable, then we can do the surgical, offer him the surgical options to reduce the portal hypertension. We can do.
No,
Uh,
I'm giving the scenario. This is same patient, 60-year male patient been who has been hospitalized for the hematomesis. So you have been asked to review the patient, right? The patient hemodynamic stable.
okay. Yes. So we can try to find out the cause and treat we need to prevent the further
What will you do?
esophageal bleed.
What will you do?
If he's a step, we can request gastroenterologist to band his esophageal varices, and we can prepare
Okay,
him for
if the patient
the
hemodynamic stable, you will ask the gastroenterologist to do the banding. Now he has done
yes.
the upper GI endoscopy. He is saying that there's no evidence of any esophageal varices.
So we can to prevent second episode, we need to reduce the portal hypertension.
I'm giving a scenario. This is the same patient. Suppose the 60-year
Yes.
male patient who has presented with hematomesis, but he is hemodynamically stable, right?
Okay.
And you have been asked to review this patient by the internal
Okay.
medicine.
Okay. For what? For operative procedure or
Yeah, they have been they are evaluating this patient, but they are unable to find out the cause.
uh, sir, no idea what to do. I don't
So
know what to do.
okay, so will you start
I
up with
can offer him.
yeah?
I can offer him with surgical treatment
Which
because
surgical treatment will you offer to the patient?
splenorenal shunts, like to reduce the portal hypertension.
Okay, no, this is the patient. Now there is no evidence of chronic liver disease. I'm
Okay.
giving you a different scenario,
Okay.
right?
Okay.
60-year male patient with hematomesis, but he is hemodynamically stable.
Okay. Then
Hmm? No evidence of
I will
CLD.
uh, he has no CLD.
Yeah.
He has CLD or no
No,
CLD.
no, no, no.
Then I will thoroughly take the history and ask
And
whether
what
he
will you
is
ask during the history?
taking NSAIDs.
No,
He is taking.
no NSAIDs. Okay, fine.
He is alcoholic. He is smoking.
Hmm.
He has any history of chronic gastritis. He belongs to. I will rule out H. pylori associated gastritis. Similarly, I will rule out gastric carcinoma. I will ask my endoscopist to see the stomach or esophagus for any ulcer that is actively bleeding. Or I will rule
What
out the.
else?
I would
What
like to
else?
know that he is taking some anticoagulants, drugs,
Okay. What else?
or antiplatelets. I would rule out all the causes. What is the cause of his upper GI bleed if it is not portal hypertension?
Okay.
So I will.
What will be the next step?
Then I will. Uh, he is not bleeding, so I can, as patient is stable, I can do angiography to see whether there is or chromium
Okay.
labeled.
Okay. Thank you.
Yes.
Thank you. Thank you, Dr. Usman.
Okay.
Now
Thank you.
take a deep breath. Okay, well done.
अच्छा
Yeah, Dr. Noman.
मेरे ख्याल में अस्सलाम वालेकुम
Oh,
Assalamu alaikum.
बहुत शुक्रिया
Amir,
अब तू बड़ा
many
बन गया यार
सर बड़े
congratulations.
नहीं कराएंगे.
हाँ
नहीं सर ये कैसे हो सकता है रिकॉर्डिंग शुरू करते हैं
Okay, so Numan, now you can. The house is open for the discussion and comments.
मैं कह रहा था कि एक तो शुरू में इस पेशेंट को सिंपल एनजी फोली का जिक्र नहीं किया है इसमें शायद
Okay.
दूसरा ये जो तू आखिर में पूछ रहा था, ये तो मेरे ख्याल में इसमें आप एंजियो डिस्प्लेजिया सोच सकते हैं, जो जिसको डायलोफाई लीजन कहते हैं मेरे ख्याल में, जिसमें आप कुछ ना हो तो फिर गैस्ट्रेक्टमी करनी पड़ती है, जिसमें आपको।
अच्छा अच्छा, इसमें ये है ना सर, इसमें ये है कि जिस तरह हाँ, अच्छा, इसमें ये है कि ये जो जिस तरह हमने स्टार्ट किया था, द फर्स्ट सिनेरियो वाज अबाउट पेशेंट इज हेमोडायनामिक अनस्टेबल, सो यू वेंट वेरी वेल, स्टार्टेड।
तीसरा ये बता कि इसमें एयरवे की कोई रिक्वायरमेंट थी शुरू में करने की, एयरवे की?
Yes, exactly. So the patient with a massive upper GI bleed, patient is hemodynamic unstable with a systolic blood pressure of less than 80, or 80. So the patient will be having a loss of consciousness and is
Drowsiness.
at risk of aspiration. So you need to take the control of the airway. So the Usman started off very well. So he started off with the resuscitation, so securing his airway, and then moving with the circulation, putting the large bore IV cannula and giving the IV fluid, sending the blood sample for the cross match, and then you move on to the patient is not stable. Then you ask your gastroenterologist to do the upper GI endoscopy. That's a good step because the patient is he is not hemodynamically stable. So even after the endoscopy, because there's a blood inside the stomach, and he was unable to find out what the exact source, but he gave you the clue. Yes, there is more blood in the distal part of the stomach. Probably this patient is bleeding from the duodenum, right? So then you move to the duodenotomy and then find out that this is a duodenal ulcer. That was the fine. The approach to this duodenal ulcer, bleeding peptic ulcer was, I think it's quite enough. Then the approach to patient with the bleeding from the esophageal varices. So again, it was a good. So you started off with the terlipressin, initial resuscitation, then upper GI endoscopy, sclerotherapy, bending. It's not settling, responding to these measures, then going to the putting the SANC statement back more through. So after this, the endoscopists, they can attempt it for the second time for the sclerotherapy or bending. If it's not successful, so then the next step is TIPS. But before TIPS, you need to rule out whether any portal vein occlusion, extra hepatic portal vein occlusion. If there extra hepatic portal vein occlusion, so TIPS will not work. That is the contraindication. So even after the TIPS, if the patient is not responding, patient having persistent bleeding, then comes the role of surgical shunts and then liver transplantation. That is the last step. So once I gave you the scenario of patient hemodynamic stable. So in this, even in the previous scenario, you need to take the history from the patient. So you can ask the question, so about the bleeding, what's the duration of this hematomesis, amount of the blood in each episode, and for how long it's occurring, so, right, for the bleeding. And then you can ask what are the comorbids of the patient. You asked me about the anticoagulants. Is the patient having any feature suggestive of the malignancies? Similarly, is there any previous history of surgery? For example, history of surgery for the aortic aneurysm, right? What happened before the bleeding? Was there any history of forceful vomiting? That means that suggests your Miller-West tear syndrome. Is the patient taking NSAIDs? You pointed out that is the patient taking NSAIDs or not? Is there any feature suggestive of the chronic liver disease? So based upon history, you will be able to know this patient is a case of chronic liver disease. That means that most likely he will be bleeding from the esophageal varices. Now, here this is the patient of aseptic disease, already taking NSAIDs for a long time. So most likely this patient is a peptic ulcer. He's bleeding from the peptic ulcer. Now, this patient is already in ICU. He's a critically ill patient. Most likely this patient has blood stress ulceration, right? So this patient is already on the anticoagulant. He's taking anticoagulant. For example, there is a previous history of DVT. So most likely this patient, this bleeding is because of this coagulopathy. So you need to take the history and then move on to the physical examination. So again, on the physical examination, you need to see what are the features of chronic liver disease, either ascites, splenomegaly, stigmata of the chronic liver disease, right? So in case of malignancy, you will be able to find the mass, the jaundice, everything, right? So then after history, you need to mention them. History and then examination. The next step is upper GI endoscopy. even the patient, the hemodynamic stable. So you need to see what is the cause. Is there any bleeding peptic ulcer, erosion, Miller-Vestier syndrome, right? The Delphi-Lien is, you will find characteristically the normal mucosa. The underneath there's a arteriovenous malformation. But malformation. At time, if the bleeding is coming from the normal mucosa, then the endoscope is able to clinch the diagnosis. Yes, this is the problem. The treatment is injection sclerotherapy, clipping, endoscopically. So if you find this Delphi lesion while doing the gastrostomy, you have opened up the stomach, and now you have find that yes, there is a lesion. So then it's ixion. Otherwise, it's sclerotherapy and endoscopic treatment, Delphi lesion. Aortic fistula, aortic enteric, you have performed the endoscopy, you are unable to find out. So for that, you need to get the contrast and CT scan. Your endoscopy has failed. It's unable to localize. Patient is stable enough and the facility is available. Then comes the CT angioembolization. Or you can have CT angio, contrast and CT scan.
And
that
coiling.
Coiling. So even if there's no previous history of surgery, but patient may have untreated case of aortic aneurysm. So that will help make the diagnosis. So if the endoscopy is failed, so the next is CT angio embolization if it's available. So if it's not available, then surgery, depending upon your endoscopist finding. So you need to have a collaboration, need to tell us the multidisciplinary team approach in this patient, right? So this is the overview. So if you want to add something more, so you're most welcome.
Okay, my question is, I forgot to say, to do vagotomy as patient had perforated duodenal ulcer.
No.
I think vagotomy is obsolete procedure.
Yeah.
No need to do vagotomy now.
I didn't go into the postoperative care, but postoperatively, if the patient, you need to give for the H. pylori eradication therapy. So that is sufficient. And the patient taking the NSAID, you need to cover with the PPI. So there's no role of vagotomy in these.
Now, there is no role of vagotomy in modern surgery after proton pump inhibitors are available. You just give proton pump inhibitors. It is of historical interest that vagotomy.
Yeah. And one more thing, while doing the duodenotomy, the first step is mobilizing the duodenum. So just do the cauterization. That will help to control the bleed. You can put your index finger behind the duodenum, and you can compress with the help of index finger and the thumb. You can control it. So anything which Amir can add in the scenario or the discussion? Any other thing?
In the upper GI bleed, the most common causes, as you have enumerated, they are basically gastroesophageal varices. They bleed profusely. Then is this acid peptic disease, gastric ulcer, or duodenal ulcer. They can bleed profusely. And then there are gastric varices and these Delafield lesions. Mallory-Weiss tears, they bleed. They have small bleed. Similarly, stress ulcerations, they generally cause very small bleed. And it's basically an altered, what they called, yeah. Yeah. So and even aortic enteric fistula, it's bleeding is not much generally. Yeah, though one thinks that its aorta is opening into the gut, it would bleed a lot, but it doesn't. So very well, sir. You have gone through all the history, and so we can have one feature because we don't have that much time. Is there any history of surgery for one can prepare for each scenario? That for gastric varices, to know if there is any history of liver stigmata of liver disease. I would like to ask any history of previous peptic like surgery for aorta, suggesting aorta enteric fistula or something like that. And in any upper GI bleed, as Sir Numan said, that it's a must to put in a NG. NG would tell us that whether it's from upside or from below. So that's it. Most probably these are the things. And regarding the management, then that is a separate topic, portosystemic circulation, in which if the patient is unstable, then we will just resuscitate. There is role of in that portal hypertension. We need to decrease the portal pressure by giving terlipressin and octreotide and things like that. And then there are shunts which are selective and non-selective, like mesocable and other shunts. H-type shunt and splenorenal is the basically selective shunt that devascularizes or decreases the pressure towards the coronary vein, and then decreases the pressure towards the esophageal varices from the
left side.
short gastric vessels.
Right.
Left side.
Right.
So,
Left
sir,
gastric
very
papillary and
well
short gastric.
made scenario and very well responded, Usman.
Thank you.
Mashallah, very well.
One more thing is on and that Rockall scoring system. So
Yes.
that will give an idea the risk of the rebleeding. So that includes the age, patient age, patient's
Comorbidities.
comorbid, circulatory failure, or the ischemic heart disease, liver failure, renal failure, or disseminated malignancies. Number 3, the endoscopic findings. So is there any blood, visible spurter? There's a clot is adherent to the ulcer, and then the diagnosis. What is the diagnosis? So is it a Malarious tear syndrome or something else? So the tumor or the bleeding peptic ulcer. So that gives you an idea of whether the patient is going to rebleed or not, right?
So regarding one thing regarding that is Delphi lesions, they are basically in the fundus, and at times they are inaccessible for injection sclerotherapy. So they apply gel, cyanoacrylate gel. So it solidifies the vessel and it sort of seals it. So that is one of the modality, apart from clipping and injections that you have told, sir.
So we will, as a surgeon, we will be involved once the endoscopist, the medical team, they're already managing these patients. And most of the time they will call us for the surgical intervention. They are unable to control the bleeding, and then they will call us. So that will be the scenario. So we should be knowing that, okay, we need to ask the endoscopy, what are the findings of the upper GI endoscopy? Even the upper GI endoscopy can be should be performed in the operation theater. The patient is hemodynamic unstable. So at the same time, you're putting the scope and you are actually performing your aprotomy. So that the endoscopy will give you an idea of where is the source of the bleeding. So I think as a surgeon, we should be knowing about the treatment of the bleeding peptic ulcer. So are the bleeding gastric ulcer? In the gastric ulcer, we need to take the biopsy at least. So rest of the esophageal varices, I think that doesn't come under the domain of the general surgeon. As a surgeon, most of the treatment is with the endoscopist or interventional radiologist. But we should be knowing the approach.
The approach, the shunts, management of gastric ulcer, management of duodenal ulcer, and a bit of about procedures like devascularization, procedures like Figura or other.
Okay, let me ask you, Usman. Usman, if the patient has a known case of carcinoma stomach and he has reported back to you with hematomesis, now what will you do? Usman has left. Usman?
Usman वापस आ गया.
Usman? Hello. If suppose this patient has a known case of carcinoma stomach, now he has reported back to you with history of hematomesis. Now what will you do?
If he is a patient of adenocarcinoma stomach and he has bleeding, I will approach the patient. I will, according to the, I will first of all, according ABC, stabilize the patient if he is hemodynamically stable.
He is stable.
Yes, then I will do workup for carcinoma stomach.
What
As
will you do?
first of all, I will ask the gastroenterologist to take biopsy, and I will confirm
He's already,
which
he is a proven case. He is he's
then I
already.
will stage the disease. I will do endoscopic ultrasound to see the T stage of the disease, and CT scan of the abdomen and pelvis to do the nodal state, check the nodal status, and I will also look for any metastasis in the liver. If it is a early carcinoma of the stomach, then I can manage it accordingly, according to the stage of the disease, and I will like to perform, take the case into the multidisciplinary tumor board, where I will sit with the radiologist, I will sit with the oncologist, and
Patient is having
I will.
recurrent episodes of hematomesis.
Okay, the treatment will be according to the location of the tumor, and whether it is it possible to do curative resection or just we have to do the palliative resection. Because in the case of
The tumor is fixed to the posterior abdominal wall, is fixed with involving the major vessels. What will you do?
then I will counsel the attendants of the patient that nothing can be done regarding the curative resection of the tumor. We can just palliate that
How will you
symptoms.
palliate? How will you palliate it?
I will ask gastroenterologist to see whether there is bleeding from the base of the ulcer or where, if
He
we
has
can.
done the upper GI endoscopy. He has done the upper GI endoscopy. He has noticed that there is a tribal mass and it's bleeding, but he is unable to control the bleeding with the endoscopy. He tried the ablation, he tried the sclerotherapy, but he's unable to do that. He's unable to control the bleeding.
Then we can do the segmental resection of the stomach, just palliative resection of the stomach. We can do partial gastrectomy depending if it is a distal tumor, and if it is a proximal tumor, then we have to do gastrectomy, but it is non-oncological surgery.
Thank you.
Just palliative.
जो scenario मैंने दिया ना कि this is the known case of CA stomach. So he has presented with hematomesis. तो आप start उससे ही लें कि जी I will start up with the history. History में वही सवाल उससे पूछेंगे भाई कितने अरसे से क्या है, ठीक है? History then examination इस तरह मूव करेंगे भी आपके हेमोडायनामिक स्टेटस के मैंने कहा था स्टेबल है, लेकिन हिस्ट्री तो उससे लेंगे ना भाई कितने अरसे से है, उसकी क्या स्टेज है, क्लिनिकल अपने स्टेजिंग करनी होगी कि डज इट लुक टू बी सीम्स टू बी मेटास्टेटिक डिजीज, वो तो आपकी हिस्ट्री में पता चल जाएगा, ठीक है? और प्रीवियस उसकी इन्वेस्टिगेशंस क्या हुई है, ट्रीटमेंट क्या हुई है, उसको क्या मिली हुई, आप ये सारी चीजें एग्जामिनर से पूछेंगे, ठीक है? कि मैं ये उससे पूछूंगा, फिर उसके बाद आगे जाएंगे। और बेसिकली ट्रीटमेंट वही है, इसकी बेसिकली लोकल है, टेपी आर्गन एब्लेशन है जो करते हैं, स्क्लेरोथेरेपी है, एंडोस्कोपी क्लिप यू कैन अप्लाई द क्लिप, और फिर पैलिएटिव रिसेक्शन अगर एंडोस्कोपी, उससे पहले क्या है एंजियो एम्बोलाइजेशन इन दिस केस, ठीक है? ठीक। सो चलिए जी, हमने वी हैव डिस्कस दिस केस द अपर जीए ब्लीड. We went through the different scenario, patient who is hemodynamic unstable and he's bleeding from the duodenal ulcer, and then we move to the esophageal varices. Then we talk about the different causes of the upper GI bleeding and their management, but the carcinoma stomach, Maillard-Vestier syndrome, Delphi. Let's move to a next scenario. So Amir is here. He has recently passed his exams. Now he will be an examiner. So would you like to be an examiner for this next scenario or not?
Sir, as you say, sir.
Huh? What do you think, sir? So the next who is the next candidate? Dr. Numan, you are the next candidate. Okay. I give you the time, so you can think over it. You can give your scenario.
Oh, no problem, sir. I'll ask. Okay, sir. There is a 67-year-old male. He has presented to you in the OPD with the history of fever, and left-sided abdominal pain. Uh, he also has features of diarrhea, and he is his pulse is 105 per minute, and his temperature is 38.5, and his blood pressure is 100 by 60 millimeter of mercury. How would you approach this case?
The patient is an old man with fever and left-sided abdominal pain. I will admit this patient and start with. I will take history, thorough history, along with. I will start managing along with passing. Preferably two large bore IV cannulas and start him with IV fluids, antipyretics, and painkillers and paracetamol IV. Uh, I will pass him folic ester, and meanwhile I will take history of his fever, duration of fever, and the history of pain, its duration, its relation to food intake, its relation, aggravating and relieving factors. And I will ask about
The
urinary and bowel.
patient is sick and he is not able to give that long history.
So any
His BP
attendant,
is 100 by 60.
any attendant who is accompanying, I can, if any attendant is accompanying, I can ask from him if patient's attendant is with him, and if there is no
So
attendant,
they are worried about the patient, and they say that you can ask briefly. What briefly you want to ask?
okay, I will just ask salient features like any urinary or bowel complaints and any previous history of
The
comorbids.
patient is having diarrhea. Also passed some blood few days
For
ago in the
how many days he's having diarrhea?
for the last 2-3 days he is having diarrhea.
Okay, and any comorbids or any drug intake, drugs?
Yeah, patient is a known case of ischemic heart.
So, and any history of similar episodes in the past? I will ask specifically that does he had any similar episodes in the past?
Yeah, he had around sick. He had a similar complaint 6 months ago,
Okay, so
and he was hospitalized for 3 days.
okay, so after taking detailed, I have taken detailed history. Then I will examine the patient. I will examine after checking his vital signs again.
What is your in your mind, Dr. Numan?
This patient may have. I will keep two or
Give me
three.
three diagnoses.
He may have diverticular disease. He may be bleeding from diverticular. He may have inflammatory bowel disease, or he may have mesenteric infarction as well, mesenteric ischemia or mesenteric infarction. So I will keep these three in my mind, and I will, along with resuscitation, I will start investigations, urgent investigation. I will send his blood for grouping cross match, complete picture, LFTs and amylase and RFTs and hepatitis profile. And I will order a bedside ultrasound and
Okay, ultrasound is done, and its abdomen is full of gases.
okay, so the patient is in obstruction. I
The
will
HB is 9 grams per deciliter. You did the HB and hemoglobin, and it's 9 grams per deciliter.
so I have to perform a digital rectal examination also to see what is the status there. And after that, if the patient is stabilized vitally, I will request for a contrast enhanced CT scan abdomen. Uh,
Okay, the patient was stabilized, and contrast enhanced CT scan was done, and it showed a large abscess in the pelvis, and there are multiple outpoachings in the cecum as well as a sigmoid colon.
Okay, so this patient is likely having diverticular disease, and he has an abscess secondary to diverticulitis. So in this case, I would preferably I would request my interventional radiologist to drain the abscess under radiological guidance and possibly insert a drain or a pigtail catheter inside the abscess cavity. And I will send the pus for culture and sensitivity to start the appropriate antibiotics.
Yeah, radiologist tried, but the cavity is multiloculated, and he is unable to drain all the cavity,
Okay,
all the pockets.
so the next option is then the next option is surgical exploration and uh, surgically drain the abscess. So I will give, I will try to stabilize the patient for surgery. I will uh, involve the senior anesthetist to see his check his optimization to undergo a major surgery, as he's a patient of ischemic heart disease and he's also taking multiple drugs. And if he is stable enough to undergo surgery, then we will plan for lower midline laparotomy, and we will then take him to operation theater. After we will arrange the blood, we will
Okay,
optimize
you
his.
did lower midline laparotomy. What will you do in the laparotomy?
So in this case, our focus is to reduce the septic load mainly. So we will drain the abscess. We will do a thorough lavage of the pelvic cavity, and we will assess the large gut. Uh, if it's okay, then I think at this stage only we will place a drain and close the abdomen.
Okay, the patient is stable, but what else you can do for the cecal and the sigmoid diverticulitis?
So we can we I will involve my senior colorectal surgeon to make the decision regarding this surgery, and we may plan for a subtotal colectomy with ileostomy and subtotal colectomy with ileostomy for the time being.
And what will you do with the rectal stump?
So we will close the stump. In this surgery, we will close the stump and we mark it with a non-absorbable suture like proline. And we may plan a reconstructive surgery later on when the patient is completely stabilized, his infection has settled, and his nutrition status has improved, and he is fit to undergo a major reconstructive surgery.
Okay, you were about to close the abdomen once the anesthetist tells you that the patient has lost his BP is unrecordable. What will you do?
Okay, so I have to look at the causes why he's having uh, hypotension. I will look at any hemorrhaging site in the abdomen. The abdomen is closed or it is still open?
Yeah, you have closed the abdomen. There is nothing in the drain.
Okay, so there's nothing in the drain. Then I will ask the anesthetist to rule out any cause from anesthetic side, like any drugs which can cause hypotension, or any mismatched transfusion, or any chest condition like any hypersensitivity reaction to any antibiotic, or maybe tension pneumothorax. So I will ask my in collaboration with my anesthetic colleague, I will try to rule out these conditions.
Okay, there was end tidal readings were not uh, of the usual pattern. Then what do you suspect has gone wrong with the patient?
And title volume.
Carbon dioxide.
I think he may be having pneumothorax. I'm not sure.
Okay. So the patient's tube was temporarily disconnected, and the end tidal readings were abnormal, and the anesthetist identified and corrected the airway, and the patient got well. Okay, thank you very much, Dr. Numan.
Thank you. Thank you. अच्छा इसमें क्या गलतियां की हैं?
Well done, sir.
Sir,
you performed
sir,
well.
very well done. But पहली तो आपने वो है कि मैंने थोड़ा सा आपको बीच बीच में फंसाता गया. It was a very well responded scenario. थोड़ा सा सर ये है कि मोटी बात करें, try to जो है ना डिटेल में ना जाए उसमें कि जी बहुत ज्यादा जैसे आप कह रहे हैं ना मैं इसको पैरासीटामोल भी दूंगा, मैं इसको ये भी दूंगा, मैं उसको वो भी दूंगा. आप कहें कि आई वुड रिससिटेट द पेशेंट.
अच्छा.
हाँ, बस मोटी बात करें कि जी द पेशेंट रिक्वायर्स रिससिटेशन, आई वुड रिससिटेट द पेशेंट. फिर अगर कोई पूछता है तो फिर आप बात करें कि जी आई वुड गिव आईवी फ्लूइड, आई विल गिव फलाना, आई विल गिव ये और आई वुड गिव दैट. तो इसमें वही है diverticulitis मोस्ट प्रोबेबल वो बन रहा था. फिर ये हिंची टाइप 2 मैंने बनाया, फिर उसको थोड़ा सा कॉम्प्लेक्स करके तो मैंने आपके लिए आपसे लेप्रोटमी उसमें वो करवा लिया. तो इसमें सर कैंसर आपने रूल आउट करना है, मेलिग्नेंसी रूल आउट करनी है, इन्फ्लेमेटरी बाउल डिजीज, क्रोहन अल्सरेटिव कोलाइटिस वो रूल आउट करनी है, इस्केमिक, हाँ, फिर टीबी रूल आउट करनी है. और फिर उसके बाद जो है ना आपने ये जो इस्केमिक बाउल आपने जैसे कहा कि वो भी रूल आउट करनी है कि इस्केमिक हार्ट डिजीज का पेशेंट है तो इस्केमिक बाउल भी हो सकती है. तो मोटी मोटी आपने चीज़ें बेहतर बताई हैं. फिर उसमें बाकी और ये हो सकता है कि
की जो है ना,
जी सर,
इन्फेक्टिव
इन्फेक्टिव
कोलाइटिस की जो है ना कॉजेज जो है ना कि वो
हाँ, क्योंकि अब शॉर्ट हिस्ट्री है तो इन्फेक्टिव कोलाइटिस जो है ना वो इसमें मतलब वो भी एक ऑप्शन हो सकती है, क्योंकि वो इसी तरह से प्रेजेंट करती है कि अचानक से इन्फेक्टिव कोलाइटिस में पेन होती है, फीवर होती है, और साथ जो है एब्डोमिनल डिस्टेंशन हो जाता है, ब्लीड भी करता है पेशेंट एट टाइम्स. इतनी डिस्टेंशन हो जाती है कि यू हैव टू गो फॉर सबटोटल. तो ये हो गया सर. और बाकी वो है कि रिससिटेट का कहें, आईवी फ्लूइड्स वगैरह का कहें, ब्लड वगैरह का वो कर लें, और फिर रिससिटेशन करने के बाद वो आपने सीटी पे थोड़ा सा लेट गए, रिससिटेट करें, और फिर उसके बाद सीटी को करा लें. एक्सरेज नहीं कराया आपने, एक्सरेज करा लें, अल्ट्रासाउंड पे पहले चले गए. तो एक्सरे जो है वो शुरू में आपको कराना चाहिए. और बाकी जो है ये बेस लाइन्स कह दें, अगर किसी आप उसको इन्वेस्टिगेशन को स्ट्रेस करना चाहते हैं तो देन यू कैन से दैट कि जी ये स्पेसिफिकली मैं कराऊंगा. बाकी जो है वो बेस लाइन कह के तो यू कैन जस्ट मूव ओवर. मतलब बेसिकली हमने मोटी बात करनी है और ये बताना है कि जी मुझे ये भी पता है, मुझे ये भी पता है, और मुझे ये भी पता है, और मैं इस तरह से रूल आउट करूंगा. आई वुड लाइक टू नो दिस और आई वुड लाइक टू नो दैट. तो बाकी सर बेहतरीन है. इसमें सब टोटल कलेक्टमी और फिर आपकी कोई बनेगी एंडालियोस्टमी और हार्टमैन्स प्रोसीजर बनेगा. और बाकी है कि जब ये अनस्टेबल हो गया तो फिर एयरवे ब्रीथिंग सर्कुलेशन एबीसी से शुरू करना है. एयरवे को आप पहले रखेंगे, एयरवे आप भूल गए, तो उस हिसाब से फिर जो है मैंने एंटाइटल कार्बन डाइऑक्साइड आपकी वो उसकी रीडिंग्स नॉर्मल कर दी. तो ये वो है कि सर एयरवे को पहले रखें.
ठीक है.
तो बेहतरीन हो गया सर, माशाल्लाह आपने बड़ा अच्छा जवाब दिया.
नहीं बस गुजारा ही है और बस चलो.
नहीं सर, ये पहले दिनों के हिसाब से आप माशाल्लाह बहुत अच्छे हैं. हम पहले दूसरे हफ्ते में बिल्कुल जो है ना वो ललित थे. ठीक है, ये सर शफाकत की बात नहीं कर रहा, लेस सर शफाकत. सर शफाकत तो माशाल्लाह पहले दिन से प्रोफेसर है.
शफाकत तो वैसे ही.
माशाल्लाह टीचिंग सेटअप से आ रहे थे आप. जी सर,
बोले बोले
एनी कमेंट? जी सर.
हाँ, मैं कुछ कहना चाह रहे थे आप ना.
जी सर, बस मैं यही कह रहा था कि आप टीचिंग सेटअप से आए थे तो आपको अल्हम्दुलिल्लाह एडवांटेज था, और वैसे भी माशाल्लाह आप वो हैं।
नहीं, थैंक यू। अच्छा, इसमें सिर्फ ये है कि सर बाकी तो आपने सारा सिनेरियो को लेके चले गए। आई थिंक इसको और थोड़ा सिस्टमैटिकली कर लेना। Start history of the patient unstable. Obviously, you mentioned that I would resuscitate the patient. Then ask the history, then move on to the examination, abdominal examination, then digital rectal examination. but एक systematic हो ना, तो उससे उस तरीके से आप चलते हैं, then move on to the investigation. तो अगर if you think the patient is unstable, तो inform the examiner that I will resuscitate the patient, and meanwhile I will take the history, then perform the physical examination. मतलब उस सीक्वेंस में ना वो चलते जाए, तो आगे हम उसी तरीके से चलते जाएंगे। चलें जी, नेक्स्ट जो है सिनेरियो, आमिर, यू कैन यू गिव ए, मैं कैंडिडेट बन जाता हूँ, आप
सर
एग्जाम,
ठीक होगा।
आपका एग्जाम का जो है कोई सिनेरियो वो तो हमें
चलें
सब।
सर, एक और सिनेरियो आपसे पूछते हैं।
हाँ,
सर, 45-year-old male presents to your ER with uh, left-sided abdominal pain and bleeding per rectum. He is having 3 to 4 bleeding episodes per day, and right now he has presented to you with blood pressure of 90/60, and he is having tachycardia, and he is febrile. Uh, he has no history of surgery in the past, but he had jaundice 5 years ago, and he has been advised colonoscopy, but for the last 2 years he has missed the appointments. How would you approach this patient?
okay. So this patient is right now he is a little bit hemodynamic unstable. So I would resuscitate the patient, and meanwhile I will take the history, take the detailed history. Although this patient is having a repeated episode for the lower rectal bleeding, and so I would like to ask to go into detail of the history of the bleeding and any associated history of the ultra bowel habits, the fever for the duration of the fever, and then I will ask the previous hospitalization. So, is there other investigation which has already been done? So then I move on to the examination. From the physical examination to see the abdominal examinations, if there is any tenderness, there is any mass, palpable mass, and then we'll perform the digital rectal examination to see whether there is any perineal pathology in this patient. So
So on the history, there is occasional history of admission for similar complaints, and he had uh, prolonged admission for jaundice 5 years ago.
So, is there any detail available for what was the reason for his jaundice? So, I will ask him to, can he bring his documents?
Yeah, but it was 5 years ago, and the patient doesn't remember the details, but it was not infective jaundice.
Okay, fine. Okay, so is there any history of alter bowel habits? Alter bowel habits.
The patient is having a history of uh, diarrhea, and at times his stool is well formed, and then it alternates with diarrhea.
Diarrhea.
But yeah,
Okay.
but he frequently has episodes of diarrhea.
Frequently is having, but the whole long is this patient is having frequent episodes of the diarrhea, the bleeding, and the alter bowel habits.
For the last around 3 to 4 years.
3 to 4 years. So he is having his young patient, but he's having. So I will go into the detail that the amount of the blood, amount of the diarrhea during episode per day. So I am suspecting inflammatory bowel disease, number one, in this patient, and I will keep in mind the malignancy in the patient. So I would like to rule out them. So during this current episode, so after the resuscitation, I will send this blood sample for the, for example, carcinoma branding antigen, CBC, and then I will discuss this case with the gastroenterologist for the lower GI endoscopy after doing the DRE and the proctoscopy. So,
So would you go for endoscopy in this acute episode?
right. So
Would
in
you
this,
go for endoscopy
so
during
I would
this
like to
acute
see.
episode?
So what are the findings of the examination? Is there any tenderness? So now this patient is having right now he has presented with the fever, pain, and he's also complaining of the bleeding, right? So
Yeah,
is there any evidence of the what are the findings of the abdominal examination?
the abdomen is mildly distended, and there is no tenderness. But on DRE, there is blood and mucus on the finger.
Blood on the finger,
Blood and mucus on the examination.
but there is no tenderness. But patient is having fever.
Yeah, patient is having fever.
Okay, I will send the samples, say the stool samples for the ova cyst culture to see whether there are any infective cause of the colitis, whether the patient having, and start up with the antibiotics and see the response to the patient response.
Okay, the patient responds, and after 4 or 5 days, he is doing well, and but his diarrhea has decreased with your
Okay.
treatment, and now he is hemodynamically stable. So, how would you confirm your diagnosis?
So I will get the contrast and CT scan of the abdomen and pelvis to see whether there, what is its cause. Uh, is there any evidence of a colitis or the diverticular disease in this patient, and is there any mass?
There is on you did the contrast enhanced CT scan, and the patient, apart from having two normal kidneys, is having another serous kidney like opacity in the left iliac region.
Okay.
What would you do?
So there are two normal kidneys, and there's another kidney shaped structure which is in the left
The
lower part.
left serous shaped kidney, kidney like lesion in the left iliac region.
So I will discuss with the radiologist, and I will explore what are the characteristics of the lesion, what could be. So I will ask him to comment on the bowel. What are is there any findings which are related to the bowel?
Yeah, it's in relation to the bowel.
It is in relation to the. Is it within the bowel?
Yeah, it's occupying the same shadow of the bowel.
Same shadow of the bowel. Okay. So is there any fat standing? Are there any evidence of fluid collection?
No, there is no fluid collection. So, what do you understand from this serous-shaped kidney mass in the distribution of the bowel? What do you suspect?
I'm suspecting probably this patient has in the shape in the region of the bowel. So this could be a malignant mass. And what is the size? It's a sigmoid colon. It's in sigmoid colon. No?
Yeah, at the sigmoid colon.
Sigmoid colon.
In the distribution of sigmoid colon.
Sigmoid colon. Yeah. So it could be a malignant lesion as well.
Okay, the radiologist says that it's most likely adenocarcinoma of the sigmoid colon. So, yeah. How would you proceed next?
So next is I will discuss this case with the gastroenterologist, and I will ask to do the colonoscopy to take the biopsies, and meanwhile we'll also take the patient the multidisciplinary team, and we'll discuss the case over there as well. So I will wait for the endoscopy and the biopsy, colonoscopy and biopsies. So meanwhile, send the other investigations as well.
Okay. The patient was also taking ursodeoxycholic acid.
Okay.
Before coming to this to the hospital, since he had jaundice 5 years ago. Is there any relationship between jaundice and this mass?
Mass in this case, the cholelithiasis, hiatus hernia, and sigma. Are you talking about the Staines triad?
No. Saints triad is hiatus hernia, cholelithiasis. So it was not cholelithiasis, it was jaundice. And since then he is taking ursodeoxycholic acid.
Yes. Okay.
And he is also on infliximab.
Infliximab. Infliximab for the inflammatory bowel disease. So when the
Yes.
patient, yes, the inflammatory bowel disease patients, they can develop the sclerosing cholangitis as well. So the sclerosing cholangitis, these medicines, the medication is given to them so that in order to prevent the development of the gallstones. So, and this
Okay.
patient that is the risk factor, and this patient has developed malignancy.
So, okay. So, what do you think is the risk once you have sclerosing cholangitis as well as inflammatory bowel disease?
Yes, the inflammatory bowel disease, they has extra intestinal manifestation, which primary sclerosing cholangitis is one of them. And these patients are at risk of developing the malignancies.
Okay, how can you decrease the risk of developing malignancy in inflammatory bowel disease?
But in case of inflammatory bowel disease, so inflammatory bowel this surgery, it reduces the intestinal manifestations. So it reduces eliminates the risk, almost eliminates the risk of the GI bowel malignancy, but it will not eliminate the risk of the primary sclerosing cholangitis and later on developing the malignancy in the biliary tract. So
okay, anything short of surgery
for this primary sclerosing cholangitis. Hello, the video is stuck. Yeah, and you are talking about the primary sclerosing cholangitis?
Yeah, primary sclerosing cholangitis and inflammatory bowel disease. Inflammatory bowel disease in particular.
Inflammatory bowel, obviously. So it depends upon the inflammatory bowel disease. Is it a ulcerative colitis? It's a Crohn disease. So it's a colon involved. Most likely, it will be ulcerative colitis. So the initial treatment is a medical treatment. So, for example, of 5-aminosalicylic acid, Asacol, then comes the steroids. Then the long-term patient, once the patient go into the remission, then infliximab, and there are other monoclonal antibodies. So these, but the indication of surgery in the inflammatory bowel disease, if the patient is not responding to the medical treatment and the medical treatment is causing the side effects, the patient is developing complications later to the inflammatory bowel disease. So medical treatment is first.
Okay, okay. Thank you. Thank you, sir. Thank you, Dr. Shafqat.
Thank you. G, now give me the feedback.
Sir, basically this is a scenario in which primary sclerosing cholangitis, and you went very well through the scenario, mashallah. लेकिन इसमें सर वो है कि एक तो मैंने once I gave you history of jaundice repeatedly, you should have picked it up a bit earlier कि ये इसके साथ sclerosing cholangitis जो है that is a also predisposing condition जो कि
there was only one hospitalization 5 years ago. There was only one hospitalization for jaundice, no?
Yeah.
Okay.
And since then he is taking some drug ना. तो अब इसमें ये है कि सर बेसिकली और ये जो है once primary sclerosing cholangitis and inflammatory bowel disease they are together, then the risk is intensified for colon malignancy. वैसे जो है जैसे 7-8 years पे हुआ तो इसको तीसरे चौथे साल में malignancy बन गई है. अच्छा, दूसरी चीज जो है सर ये जो अपने बड़ा वो अच्छे तरीके से लेके चलें, एक पॉइंट सिर्फ और है, वो ये है कि अगर रिमिशन जो है ना, वो आज मैंने पढ़ा मेडस्केप पे, ये बेसिकली एक जैसे आप केस रिपोर्ट पढ़ते थे ना, मैं भी केस रिपोर्ट पढ़ के आया हूँ आज। तो वो उसमें उसने कहा कि जी बेसिकली अगर इफ यू मेंटेन रिमिशन, लॉन्ग मेंटेनेंस ऑफ रिमिशन जो है ना, दैट रिड्यूसेस द रिस्क फैक्टर फॉर मेलिग्नेंसी। तो ये बेसिकली एक दो पॉइंट्स थे टोटल जो मैंने कहा कि मैं जिस पे आज ये सिनेरियो पे बात करूंगा। बाकी तो फिर हमने मेलिग्नेंसी पहले भी डिस्कस की हुई है सिग्माइड की। और
वैसे बनाया आपने?
जी सर।
ये आपका एग्जाम का सिनेरियो था कि ये आपने वैसे बनाया?
नहीं सर, ये मेडस्केप से उठाया आज।
अच्छा, उधर से उठाया, ठीक है। यानी आपने वो
हाँ
वाले हमें सिनेरियो पूछने हैं, अभी 3
जी
सिनेरियो
सर वो,
है ना?
जी
ठीक
सर
हो गया,
वो भी इंशाल्लाह। जी सर।
ठीक हो गया, गुड हो गया। सो
तो
सर नुमान
उस्मान,
या उस्मान, आपकी तरफ से
चलें,
भी
नहीं ठीक
इनपुट?
है यार, बड़ा अच्छा तुमने किया, सारा
अच्छा
कुछ
ठीक
आमिर ने बताया।
है। ठीक है, चलिए सर तो वैसे खत्म कर दे, बट ठीक है।
नहीं अभी दो लोअर जीआई के हो गए ना सर। सिग्माइड भी डिस्कस हो गया आज, और इन्फ्लेमेटरी बाउल डिजीज भी, यानी और
हाँ,
मेलिग्नेंसी भी
और एक
सॉर्ट
हमने
ऑफ
अपर
डिस्कस
जीए
हो
का
गया।
कर लिया, अपर
जी
जीए
सर।
भी कर लिया। ठीक
तो
है,
ये माशाल्लाह ठीक हो गया, 3 सिनेरियोज हो गए,
हाँ ठीक है।
तो बेहतरीन हो गया।
उस्मान आपकी तरफ से कोई चीज, सो दैट वी कैन फिनिश इट ऑफ।
सिर्फ एक
उस्मान
सवाल
हैज
था कि
रेड।
हाँ, हाँ बोलें।
ये जो अभी सर ने सिनेरियो दिया है ये बेसिकली क्रोन्स के साथ रिलेटेड था कि इट वाज स्ट्रक्चर दैट वाज कॉजिंग, या अल्सरेटिव कोलाइटिस था ये इन्फ्लेमेटरी बाउल
अल्सरेटिव
डिजीज में?
कोलाइटिस, अल्सरेटिव
अल्सरेटिव
कोलाइटिस
कोलाइटिस था।
बेसिकली, अल्सरेटिव
अल्सरेटिव
कोलाइटिस तो
कोलाइटिस।
बेसिकली इसमें इन्फ्लेमेटरी बाउल डिजीज, और जब ये प्राइमरी स्क्लेरोजिंग कोलेंजाइटिस मिल जाता है ना, तो फिर वो रिस्क बढ़ जाता है। तो
हाँ ठीक है।
बेसिकली ये पॉइंट था कि थोड़ा सा स्ट्रेस कर लें कि अगर कोई जॉन्डस के
हम्म,
साथ सिनेरियो दे देता है तो उसको हमने थोड़ा सा पकड़ना है।
हम्म,
और दूसरी चीज आ गई सर, जो मैंने वो बात की है कि भाई रिमिशन वाला उसमें लिखा हुआ था कि जी रिमिशन अगर मेंटेन रखें, कॉन्टिन्यूस मेंटेनेंस ऑफ रिमिशन जो है, रिलैप्स ना होने दें, तो वो एक रिस्क फैक्टर को कम करता है। बाकी फिर वो सर्विलेंस क्लोनोस्कोपीज हैं, और कोई है कोलेक्टमी है। डेफिनेटिव रिस्क रिडक्शन तो
हम्म,
कोलेक्टमी है कि कोलेक्टमी से आप
एग्जैक्टली,
कर सकते हैं।
उतने सिनेरियो बनाया, इस तरह सिनेरियो होना चाहिए जिसमें जो कैंडिडेट उसको सोचने का पड़े, वो उसका फिर दिमाग चले, ब्रेन स्टॉर्मिंग उसको करनी पड़े,
हम्म।
पूछे ये क्या हो सकता है, ये क्या है ना। तो थैंक यू सो मच आमिर फॉर मेकिंग दिस सिनेरियो।
ओके सर, मैंने कहा कि ये बाकी तो आपने फिर वो सादे सादे है ना, वो थोड़े से आप उसमें सीधे सीधे
नहीं, अच्छी
चले
बात है,
जाएंगे।
वही मैं कह रहा हूँ, आप
तो मैंने
लेके
कहा
आए
थोड़ा
केस
सा
रिपोर्ट
आपका
पढ़ें। हाँ,
माइंड को एजिटेट करें आपके थोड़ा सा,
एग्जैक्टली,
ताकि
हाँ एग्जैक्टली, केस रिपोर्ट लेके आए उसमें से करके, तो फिर उसमें से सिनेरियो बना लें। तो चलिए जी, हम फिर इसको समराइज कर देते हैं। So today we discussed 3 case scenarios. The first scenario was about upper GI bleed, in which we discussed the management of the patient who presented in shock, in a condition of shock. So the initial management, and then the surgical intervention for the bleeding peptic ulcers, aortic enteric fistula, carcinoma stomach, and different causes. So the next scenario was uh, about diverticulitis, complicated diverticulitis. So it's initial investigations and how to approach them with drainage, and then later on, if the patient it's multiloculated, so drainage will not be effective. So then we have to move on to the surgical drainage. Then the third scenario of inflammatory bowel disease, which has been complicated by the primary sclerosing cholangitis. Ultimately, the patient developed the carcinoma. So it's very important to keep in mind that in case of the patient who has uh, developed the primary sclerosing cholangitis and is already taking the medication to prevent the development of the gallstones, we must keep in mind that patient might be having a primary sclerosing cholangitis, which is one of the extra intestinal manifestation of the inflammatory bowel disease. And with this, the risk of the malignancy is increases. And if the patient remains in remission for a prolonged time, so the risk of malignancy, development of the malignancy, it drops down substantially. So thank you so much for joining us, Amir, for making 2 scenarios, and Dr. Usman, Dr. Numan Tasneem, and Dr. Mizan is also here, but he is muted. Thank you so much.
Sir, call mute कर लें sir.
Thank you so much. Thank you so
Okay
much.
sir,
Thank
thank you.
See
Thank
you
you.
again. Thank you.
Thank
Bye.
you.